it's my pleasure to introduce a really close friend of not only of mine, but of all of ours, Dr. Otis Brawley. Otis is the Bloomberg Distinguished Professor in both the departments of Oncology and Epidemiology here at Hopkins. Prior to his recruitment here a couple of years back, he was the Chief Scientific Officer at the American Cancer Society for about a decade. And prior to that, he was both at Emory University and was the Cancer Center Director of the Grady Memorial Hospital Cancer Center in Atlanta. We've known Otis a long time. He certainly was one of the pioneers in moving the issues of cancer health disparities to the forefront of our scientific and intervention agenda.
Hi.
And
I'm looking at the door, Aaron, so I'm not looking at email and I didn't listen to voicemail. So what's up?
You're walking out the door to what?
I think we need some muting.
Oh, I'm just sending you a
So again, without further ado, Otis, why don't you take us forward in the issue that now that we're in celebrating the 50th anniversary of the National Cancer Act, has really become much to our forefront in sort of seeing what we've really accomplished that has done particularly well over the last 50 years, and perhaps some perspectives of what we can do better over the next several decades. So, Otis, you there?
Yep, I'm here. Thank you for having me today. And John, I assume you can see my slides and my cursor moving right now.
Yep, looks good.
Okay, superb. It's wonderful to talk to you about the National Cancer Act and the Cancer History Project. Here you have some of my disclosures, really important to this talk, except I am one of the editors of the Cancer History Project. I also wrote a book a couple of years ago that did quite well with Paul Goldberg, and I do the Cancer History Project with Paul, but I'm not here to promote the book either. It was 50 years ago on December 23rd of last month that Richard Nixon, sorry, I have the auto advance on. Richard Nixon signed the National Cancer Act. It was the culmination of a lot of work by a number of people. I'm going to talk about what the National Cancer Act did and has done, and a little how we got to the National Cancer Act. And then I'm going to talk a little bit about the Cancer History Project, which is really an effort to try to make as much of this history available to as many people as possible. I'll start now by telling you the Cancer History Project started because at one point about 5 years ago, I kind of started feeling like Forrest Gump in that a number of people who founded oncology, which, by the way, as a medical, it was founded in the late 1960s, started. And many of these people who gotten to meet with the National Cancer, and many of them had become very good friends. And I thought other people needed to have some of the experience I had in witnessing some of these people, men and women. In any event, 50 years ago, last December, what have we gotten? I'm going to talk about what the Act did, define its effect on the funding of research and research mechanisms, and then finish by talking about the Cancer History Project. The Act resulted from Mary Ladd, a number of people at the American Cancer Society, very important to the American Association of Cancer Institute, an organization that still exists. I believe Kevin, even the president.
Otis, we're only getting about 1 out of 3 words. You know, you might consider calling in on your phone if you can.
Oh, man, okay. I'm sorry. Let me get the number to call in. Sorry about this. It's dialing.
Okay. All right, I have muted myself. I've turned down my volume. I'm sorry. What I was saying was the Cancer History Project started because about 5 or 6 years ago, I started feeling like Forrest Gump because so many of the people who founded oncology in the 1960s and 70s had started dying, aging out. And as they were aging out, I was reading obituaries. I started realizing I knew many of these people and they had been supportive of me and many other folks. And I thought, you know, there's a lot of history there that people ought to have access to. And that's how we came up with the Cancer History Project. But anyway, Richard Nixon signed the National Cancer Act on December 23rd, 1971. And let's see. And then I'm going to talk about what the Act did, define its effect on funding of research and research mechanisms. Mary Lasker and the American Cancer Society and the American Association for Cancer Institute, which are the cancer directors, were very important in actually lobbying for this over a period of almost 15 years. Prior to the National Cancer Act, it's important to know there was an original National Cancer Institute Act, it was called, in 1937. It committed $700,000 toward cancer research from the federal government. And the National Cancer Institute was brought into the NIH in 1944. In 1947, the National Cancer Institute really blossomed and reorganized into an intramural and extramural program and started a cancer control program. The Cancer Institute really didn't start giving grants out to universities until the 1960s. And a really interesting aspect of grants, which all of us live by now, is prior to the 1960s, most medical research grants were funded by private philanthropy. A couple of states, especially New York State, had their own grant funding program in cancer research, primarily to fund Roswell Park in the case of New York. Texas had another program to help fund MD Anderson. But there was very little government-funded grant research prior to the early 1960s. The Cancer Centers program started in the early 1960s, but there was no such thing as an NCI-designated cancer center. There were several cancer centers that did a lot of cancer research. They had a special relationship with the NCI, but it was, again, very informal. The development of cancer centers really started in 1967 as the concept of NCI-designated cancer centers. And then a senator named Yarborough from Texas introduced a resolution to create a panel of consultants to look at how we would have a conquest of cancer. And this war analogy really comes to us coming all the way back in the 1940s and 50s. And in 1971, NCI gave out $100 million for cancer research in various cancer research programs. This is actually the beginning of the text of the National Cancer Act of 71, and it specifically gave the Cancer Institute director a lot of orders as to what he or she was supposed to do. Initially, by the way, there were to be 15 NCI designated cancer centers. The act created a presidentially appointed National Cancer Advisory Board, a president's cancer panel, which would be 3 or 4 people who would go around the country and have hearings and write a letter every year to the President of the United States on what could be done to help overcome cancer, and made the NCI director the director of the National Cancer Program. The NCI director, as director of the cancer program, oversaw cancer efforts in all federal agencies, even agencies such as the Veterans Administration, or what was about to be created in the Nixon administration, the Environmental Protection Agency. Every year, the NCI director sends to the president a professional judgment as to what he or she felt the budget of the NCI should be in order to exploit all the scientific opportunities. This document is known as the bypass budget, and it's called a bypass budget because neither the director of the NIH or the secretary of HHS has any say in it. It's directly from the NCI director to the president. The president, by the way, every year writes a response to the letter and the bypass budget from the NCI director. It's a fascinating thing to see. It's rarely seen, but when I worked at the NCI, I literally got to read it a few times. The National Cancer Advisory Board was to be 18 people, both lay and scientific, as well as ex officio members from various areas of federal government, to include the FDA and CDC and the director of NIH within Health and Human Services, but the Secretary of Defense, Energy, Labor, VA, and so forth were all involved and still to this day sit on the National Cancer Advisory Board. The President's Cancer Panel, as I said, holds public hearings. The Act created a number of programs. The Seer Program was the beginnings of being able to count incidents of cancer in the United States. Prior to the Seer Program, we had death registries in every state, some which were better than others, and we had some idea of what the death rates were for cancer. But the Seer Program actually started getting incidents and allowed for calculation of 5-year survival rates. The Cancer Centers Program, which I already noted, would be initially 15 regional centers so people from all over the country could go get treated for cancer. It's also important to note that in the 1960s, cancer was thought of by many deans of medical schools as being not a great specialty to go into. They encouraged people to go into things like nephrology and infectious disease and cardiology, and cancer was not very well respected. Indeed, cancer was not well respected until the National Cancer Act, when there was a lot of federal money coming into cancer research. The NCI was also responsible for cancer education. This included training grants, the Physician's Data Query, or PDQ, which still exists online to get information to both physicians and patients about cancer treatment, and a Cancer Information Service, which was for a long time an 800 number. It now has an internet presence. And it also called for an expansion of the Cancer Control Program and money that was to be spent specifically on cancer prevention research, dissemination of treatment technology. The Community Clinical Oncology Program, or NCORP as it is now known, was a program that was created specifically to disseminate from cancer centers treatment technologies as they were developed into the community, with the idea that there would be doctors in the community who treat cancer patients, and they would need to be able to learn how to give chemotherapy, learn the newest and greatest treatments as research developed them. And speaking of treatments, the Developmental Therapeutics Program, which had already existed at the NCI, got a bolus of money and was really put on steroids. And you even have people from the NCI traveling the world harvesting plants and putting mulches together to look at plants and see if the mulch actually prevented, I just lost myself, see if the mulch actually prevented people, prevented cancer from growing. The clinical cooperative groups expanded. The Eastern Cooperative Group and the Cancer and Leukemia Group B started in the 1950s, but the cancer cooperative groups grew in the 1970s. At one point, there were 13 of them, as well as dramatic increases in funding to universities for research, and you'll see some data on that in a second. The Act caused more involvement in the administration of research by scientists not employed by the government. The chair of the National Cancer Advisory Board is the only chair of any of the 28 institutes and centers boards at the NIH who is not the director of that institute or center. The chair of the NCAB must be someone from outside of government. And they're boards of scientific advisors that were first set up for each NCI division, like cancer treatment or cancer control or cancer epidemiology. Later, the board of scientific advisors was for the entire institute. Now, these external advisors actually did advise and developed a great deal of power and influence, and they pushed to strengthen the NCI grants program. The move money that was going to an intramural program at the NCI into a grants program to go primarily to universities, although some companies do get grant money now. And this led to an acceleration in the evolution of how science is funded and done. Again, prior to World War II, most university research was private philanthropy or foundations, or even clinical income, which is illegal now, of course. Federal funding to research really started with World War II with contracts for malaria treatments, bacterial infection treatments, and blood banking technology. That's how medical research funded by the federal government really did start. Now, the word contract in federal world has very specific meaning. It means that the government buys a service. When the government contracts for medical research, the same laws apply when the government contracts to have a new ship built or a new airplane built or a new building built. The government sets out and says, this is what we need done and this is what we're going to buy. The contractor has very limited abilities to be innovative. They must do what the federal government has set out to be done, and the work once done is owned by the federal government. Much early research was contracts. Grants were really rare prior to the National Cancer Act and almost non-existent prior to 1960. Grants are giving people money because people have said, you know, I think this would be a great thing to do, and they make an argument that's the investigator-initiated grant. And it was really the growth of the investigator-initiated grant that really led to a lot of wonderful things from the National Cancer Act. Cooperative agreements also grew after passage of the National Cancer Act. Cooperative agreements are a grant, but it's a grant where NCI or government people are heavily involved in collaborating or working with the grantee. And cooperative agreements all start with a request for applications where the federal government says, we need more research in this area, and please send us some grants in this area. The cooperative agreement really does allow for the investigator to make some arguments as to what should be done and why. It also allows for a little bit more innovation. Even with these RFAs, the Board of Scientific Advisors, the external people, have to say, yes, this is a good idea. And the investigator-initiated grant flourished. It really took off. I have a graph of that in a second. It allows people to actually be innovative. Peer review, which was actually, by the way, invented by the National Research Council and the American Cancer Society in the 1950s, was used to determine who got the grant. Here is one of the few pieces of data I'm going to show you today. And this is showing the budget from 1974 onward. The National Cancer Act, of course, was 1971. And here in green, you have the amount of money the NCI director asked for in the bypass budget. And there are a couple of years when Harold Varmus was director of the NCI, he did not submit a bypass budget. In orange is what the president said the NCI should get as a result of having seen the ask from the NCI director. And then in purple is what Congress ultimately gave the NCI. You can see Congress usually gives the NCI a little bit more money than what the president wants to give, but it's almost always, with a few exceptions, less than what the NCI director asked for. And very important, investigator-initiated grants were 20% of a small number in 1972 and 45% of a big number in the 2010 to 2021 era. And so you can just sort of picture the growth in investigator-initiated grants. Now, this investigator-initiated grant, creativity, innovation, agility, this led to moving from a mid-19th century definition of cancer that just involved pathology to a 21st century definition of cancer. It led to an understanding of genetics and cancer as a genetic disease, led to the discovery of molecular targets and the development of targeted therapies, a better understanding of the immune system and the development of immunotherapies. And even some of our technologies in COVID, some of the mRNA vaccine was originally developed as a cancer treatment. Now, the Bayh-Dole Act, combined with the National Cancer Act, really helped to stimulate the biotechnology industry in the United States. The Bayh-Dole Act very clearly said that the results of grant research, cooperative agreement and grant research, are owned by the grantee, not by the federal government. And this stimulated the biotech industry, and some of the most interesting science has come about because of this, some of our newest diagnoses and treatment. The other thing that occurred is the development of cancer centers. Since we have 2 cancer centers here in Baltimore, I thought I'd just talk a little bit about cancer centers and their evolution. In the early 1970s, the NCI had its first 8 comprehensive cancer centers, of which Hopkins was one. In the late 70s, basic cancer centers came about, and there's still 7 basic cancer centers that do not have clinical programs. In the mid-80s, cancer prevention and control became much more important. In the mid-80s and into the 90s, we had some cancer consortiums. There was one of the 3 historically Black medical schools had a consortium at one time. There was a consortium of the Chicago area schools called the Illinois Cancer Council, and UC San Francisco and Stanford combined also had a consortium. In the 2000s, we've seen strong research bases and increased emphasis on population health, again, getting toward cancer prevention and control, and also toward community outreach and engagement. In 2010, by the way, the NCI said that directors of NCI-designated cancer centers, of which there are now 71, must have dean-level authority at universities. Now, let me just finish off a little bit with the Cancer History Project, which can be accessed at cancerhistoryproject.com. It is a collaboration and initiative by the Cancer Letter. Paul Goldberg, my co-editor of the Cancer History Project, owns the Cancer Letter as a disclosure. Everything in the Cancer History Project is free to the public. You can just go to the website and look at it. It's a platform where we're collecting data from various contributors from cancer centers, drug companies, various foundations, various patient organizations. It's also an opportunity for dialogue, and it's an archive. We've had a number of interesting things. In my Forrest Gump life, count among my friends the directors of the original 3 comprehensive cancer centers in the Anderson, Memorial Sloan Kettering, and Roswell Park. We had a 2-hour online discussion about the National Cancer Act and the role of cancer centers. We put a lot of books that are out of print on the website. Cancer Crusade by Richard Reddick is a wonderful history of the National Cancer Act. And then we have interviews and discussions with a number of really fascinating people in the history of cancer. And oftentimes the personal papers and recordings and photographs of some of the people who founded medical oncology. This is a picture of a young Emil Frywright. Emil just died last year. Dr. Frywright, a fascinating man, worked with the group that helped to do the initial cures of leukemia. He actually wrote a book. It'd be neat if I could ever write a book like this with a title, How I Cured Childhood Leukemia. And but Frywright also, by the way, was the first. He's here with a blood cell separator. He was one of the first people to ever transfuse platelets back in the 1950s at the National Institutes of Health. Recent and upcoming topics in the Cancer History Project include things like advocacy, talking about innovation, talking about legislation over the years and legislation today, talking about the cancer centers and how they have evolved. Lots of pictures, lots of papers from folks. Jane Cook Wright was one of the first people to be a member of ASCO. ASCO was founded by 60 people in New Jersey at a meeting in 1964. Jane Cook Wright is a Black woman. She was a surgeon at New York Medical College, and she's one of the first people to develop tissue culture, human tissue culture, and one of the first people to test chemotherapy against human tissue culture. And some of the rules that she wrote about chemotherapy are still in use today. This is my co-editor, Paul Goldberg. And again, our goal here is just create a point for broader discussion. We have a vast editorial board from, you can notice a number of the individuals here, Nancy Davidson, who used to be here, Cliff Hudis, who runs ASCO, my old boss from the NCI, Richard Klausner, Karen Knudsen, who now runs the American Cancer Society. And there are people from industry. Actually, I think Kevin Mace-Rothenberg was a fellow at the NCI back when you and I were there. But a number of people from a number of different places. Bruce Chabner, who was our old boss at the National Cancer Institute. Brian Drucker, of course, of Gleevec fame. Number of individuals who provided tremendous support for medical oncology have come together, and they're helping us to find things, helping us to interpret things and put them onto the website. A number of people are registered contributors. Any cancer center is usually done by the public affairs person, Amy Moan at Hopkins, can contribute to the website and things that are of historical value that institutions have. And we have amazing things. The original NSABP V6 protocol, typewritten with Bernie Fisher's handwritten notes in the margins. We have a copy of that up at the on the website. We have some of the original slides from the studies that showed that cigarette smoking caused lung cancer. Here, of course, is Bernie Fisher, who did so much in especially breast and bowel cancer, but a number of other things too, including telling us that prospective randomized trials were important. We're looking for profiles of individuals, video, questions and answers, discussions of research, milestones, previously published content that we can get permission to republish, photos, any primary sources. This is Janet Rowley, one of the who did a number of wonderful studies involving chromosomes, especially in leukemia. The support of the Cancer History Project, and by the way, no one gets paid at the Cancer History Project, neither I, Paul Goldberg, the staff is paid by the cancer letter and not, but what we get money from is to support the website, support the hardware for the website. And a number of institutions primarily, and we're looking primarily at academic institutions, although some, we have accepted some corporate money for this. We are also looking very much in involving the survivorship community. This is Ellen Stovall, who was one of the early cancer survivors and advocates for the involvement of cancer survivors. This is Gordon Zubrod. We have his papers and some of his unpublished works and published works there. Gordon Zubrod ran the chemotherapy program at the National Cancer Institute in the late 1940s into the 1970s. He trained, by the way, at Hopkins, and chemotherapy, commonly attributed to cancer nowadays, is a word that actually comes from the chemotherapy of infectious disease, use of antibiotics. And Gordon Zubrod actually brought that word into medical oncology. Donald Pinkel was the original doc in charge at St. Jude. We have a lot of his papers available as well. And so, in summary, the goal of the History Project is to collect and preserve the history of cancer research and to stimulate rigorous discussion about the achievements in not just the past half century, but really the last 70 or 80 years, and to allow young folks coming up into oncology a little bit of appreciation of where we come from, and that might give them a little bit of a glimmer of where we're going. This is the web page of the Cancer History Project as of this morning, and just give you an idea of how one enters it and how you can read about various things. And so I will stop at that point. Thank you. I apologize that my internet was not working very well today. And if you have any questions, feel free to ask.
Okay, great. Thank you, Otis. So when folks have a question, if you can raise your hand, I can enumerate that. I see Kevin with his hand waved. Let me take the prerogative of just asking Otis a first question, which is kind of getting your perspective on the impact that the National Cancer Act has had on the training of students, fellows, faculty, the ever-increasing diversity in our research and clinical workforce, and where we've come from and where we're going in this regard.
Yeah, well, the first thing that occurred was literally in the 1960s. Many people in medicine, in medical schools, thought that going into oncology, hematology was okay, but going into oncology was the stupidest thing you could do. Cancer, there's not going to be anything coming out of cancer. You're not going to be able to treat anybody. Why go into it? And so there was this huge prejudice against cancer. Actually, I've had some wonderful conversations with Vince DeVita, who was director of the National Cancer Institute when Kevin and I started there, about this. Vince is one of the people who developed MOP chemotherapy, which can now effectively cure 80+% of people who have Hodgkin's lymphoma. But the money coming in to fund cancer very quickly changed the minds of many deans of medical schools. It's interesting how that happens. They follow the money. And T32 grants started to start training programs. And literally in 1972, there were no medical oncologists in private practice, and most universities did not have a medical oncologist on staff. In the 1980s, you start seeing a large number of medical oncologists out in private practices going into community hospitals. In 1980s, you also start seeing a lot more cancer programs that are not just surgery and medical oncology and radiation, greater emphasis on cancer control. And that's where schools of public health start getting heavily involved in cancer work. And it's exploded. Now, when you look at, there's this old saying, when you look at the heads of cancer centers, the 70 some odd cancer centers, about 2000, half of the cancer center directors had trained at the National Cancer Institute. It's also true if you look at the people who are moving biotech now, even biotech for rheumatologic drugs and immunotherapy drugs and that sort of thing. The corporations, many of them trained on T32 grants stimulated by the National Cancer Act. That's one of the reasons why I actually credit Richard Nixon and the people who molded the National Cancer Act with our revolution in biotech industry and biotechnology, which is a substantial part of the American economy now.
Kevin, do you?
Otis, thanks. Great talk. If you'll indulge me, I'm going to show one slide, if I can hijack the screen.
Sure.
So this is I think for this audience, before Hopkins or Maryland had a cancer center, there was what was called the Baltimore Cancer Research Center, which was part of the NCI's intramural program back in the 60s and early 70s. And that existed until about 1978. And I have a picture, which I don't have here, which I'll send you, which has the 1970 staff of the BCR, which includes Marty Abelhoff and a number of other people who went on to found the Hopkins, went on to Hopkins, and a number of the people who founded the Cancer Center here at Maryland. But this was this is really interesting. This is the Annals of Internal Medicine 1970 paper. This was the original clinical trial of MOP chemotherapy for Hodgkin's disease. And it had 3 authors, Vince DeVita, Art Serpic, and Paul Carbone. This was before there were any specialty journals in oncology. This was the first demonstration that chemotherapy could cure what was really effectively a solid tumor. And it was done here in Baltimore, and we followed a number of the patients on this original trial. They've all passed away at this point, but just thought I would show that you can't imagine having a paper of this impact with only 3 authors. Art Serpic was the first medical oncologist in the state of Maryland outside of the National Cancer Institute, and Art is still around. He retired a few years ago. The Cancer Center up at St. Joe's is named for him. But I've got some other interesting things that we found in our archives, which I'll send you as part of this.
That'd be great. That would be wonderful to submit those. Now, one of the reasons why I sometimes say I'm the Forrest Gump of medical oncology is I've met Art Serpic. I don't know him well, but I've met him. But Paul Carbone and Vince DeVita, both became very good friends of mine, and I even know their families. The amazing thing about medical oncology, and Kevin, you might want to comment about this as well. I know I'm talking to a largely epidemiologic or public health audience, but the amazing thing about medical oncology is much of the human aspects of it have come through, and it really does have a culture of you find young people, mentor them, and help them with their careers. And Carbone died on the golf course a few years ago of a heart attack, but Vince DeVita is still very much active up at Yale.
Yeah. So other questions or comments for Dr. Brawley?
Hi, Dr. Brawley. Yes, thank you for the informative presentation. I was just curious, what is the criteria for submitting work to, kind of deem it history? I'm gonna put Dr. Gutman on the spot because I feel like he's done some amazing work with both Kinsler and, and their partnership, but I recognize, they're still relatively young, so perhaps you're looking for older. So I was curious.
There's some things that Maryland has history. You just saw a little of it there from Kevin. I mean, that was, NCI gets a lot of credit for that, but that was, that Baltimore consortium was really part of the NCI back then. Each of the cancer centers has, by virtue of the fact that they're a cancer center, has an automatic pipeline to the Cancer History Project. We just ask that people in cancer centers who might have something they think would be good for the Cancer History Project go to the cancer center's designated person to contribute, who is usually in the public affairs office. And we reserve the right to look at everything that people want to put into the Cancer History Project. But I can tell you we've been doing this now for a little over a year and a half, and we have yet to say we would prefer not to put that in because we don't think it's appropriate. We have yet to do that. And there's some really neat things like Vince DeVita gave us the original handwritten list of what he wanted to put in the DeVita Hellman Rosenberg textbook. When they first came up with the idea of that, the original outline in handwriting, there's a copy of it available in the Cancer History Project.
So other questions or comments for Otis? Well, if not, Otis, thank you for going through some of this history and laying some of these issues before us, because we really have had extraordinary successes over the last 50 years. I mean, I think the public as a whole probably doesn't appreciate how for many folks, this was when a family member had a cancer diagnosis, it became a silent diagnosis, something that wouldn't be shared among family members and friends, because it was viewed as being an ostracizing disease. And with all the successes and all of the improvements that have occurred, we've really come an enormous way, and we've got a longer way to go, given the fact that there's still major pockets of populations in our country and around the world that have a disproportionate burden of these cancers.
Yes, that's absolutely true. Absolutely true. The explosion of cancer is not just chemotherapy, radiation therapy, and surgery. Looking into the causes of cancer, looking into the epidemiology and more public health aspects of cancer. Those have all been incredibly important. And as I said, much of the technology, even PCR testing for COVID, a lot of that was stimulated by research that originated in or from the National Cancer Act. You know, it's been a huge 50-year investment. People don't realize how these sorts of investments over years can end up bearing such fruit.
All right. Well, I want to thank everyone for signing on to this Lunch Learn link. I believe our next one is February 3rd. I'm going to be the speaker, so certainly, and Otis will introduce me, and we'll go from there. So thank you again, everyone.
Thank you.
Thank you.
And, thank you
Thanks.
for
Thank you,
tolerating my
everyone.
internet
you.
problem. Take care. Bye-bye.
Thank you.